Welcome to PGOG Pathways to Progress in Obstetrics and Gynecology for Postgraduates and Consultants. Today's topic is Antiphospholipid syndrome APS in pregnancy. We have two types of immune diseases. One is autoimmune diseases and other is alloimmune or isoimmune diseases. Autoimmune is when antibodies are produced against self, whereas alloimmune is antibodies against non-self from same species. The best example for this allo or isoimmune diseases is Rh isoimmunization, where there are maternal antibodies against fetal cells. Antiphospholipid syndrome or APS, it was first identified in 1980s in SLE patient, systemic lupus erythematosus patients. It is a complex systemic autoimmune disease. So it is a systemic disease, it is autoimmune disease. Three types of autoantibodies are identified in antiphospholipid syndrome. APS is an acquired autoimmune mediated thrombophilia. That means it is not hereditary, it is acquired, and it is thrombophilia. Meaning of the terminology thrombophilia is whenever there is hypercoagulability with increased tendency to form blood clots or thrombus. Apla versus APS. Now these two terminologies, antiphospholipid antibodies and antiphospholipid syndrome. Sometimes we are confused and we do tend to use this thinking that this is one and the same, but there is a difference. Antiphospholipid antibody is Apla, whereas APS is antiphospholipid syndrome. So what is antiphospholipid syndrome is what is necessary for that is presence of antibodies, antiphospholipid antibodies along with either vascular thrombosis or pregnancy complications. So in other words, if I say patient has Apla, that is antiphospholipid antibodies are detectable in the blood. That doesn't mean that she has antiphospholipid syndrome. Reason why these two are not synonymous with each other is antibodies might be raised, mild increase in seen in small percentage of normal population also. Apla is not only raised in antiphospholipid syndrome, it is also these antibodies are raised in 30% of SLE patients and in other connective tissue disorders. So it is not specific only for antiphospholipid syndrome and antibody rise. Antiphospholipid syndrome, we can consider it as a complication because of these antiphospholipid antibodies. And Apla rise is seen with some viral infections or bacterial infections such as Treponema pallidum, syphilis, or even viral infections including COVID-19. What are phospholipids? These are the main lipid content of cell membrane of the all cells. They are also present in organelle membrane such as in the nucleus, over the nucleus, as well as over the mitochondria also. This is mitochondria, this is the nucleus. Certain plasma proteins associate with these phospholipids. There are proteins in the plasma proteins which associate with these phospholipids. Associate means there is no chemical reaction, but they do get attached with these phospholipids. Antiphospholipid antibodies are directed against phospholipids which are present over the cell membrane or nucleus or mitochondria, as well as these are directed against this plasma protein which are getting associated with these phospholipids. Now what these antiphospholipid antibodies do? They activate the procoagulants. So procoagulants are activated, there will be more of a coagulation process will be enhanced or accelerated. They will lead to inactivation of anticoagulants that will further lead to the hypercoagulability in the blood. So and there is a complement activation. So all these lead to the hypercoagulability, and that is why this antiphospholipid syndrome is called as a thrombophilia. Thrombophilia is whenever we have a state in the body where there is a hypercoagulability. What these antibodies do are they inhibit the sensitive trophoblast trophoblastic differentiation. Sensitive trophoblastic differentiation is inhibited by these autoantibodies, and all these together they lead to increase the risk of vascular thrombosis. Either there can be venous thrombosis or arterial thrombosis, and they also increase the pregnancy morbidity by increasing the complications during pregnancy. And because of these actions, they can affect every organ system because it is ultimately leading to the formation of thrombus in the vessels. Whatever vessel gets affected, accordingly that organ can get affected. So every organ in the body has a potential. These antiphospholipid antibodies have a potential to affect every organ system in our body. Three types of antiphospholipid syndromes are described. First is called as VAPS, vascular antiphospholipid syndrome, which is where there is a thrombotic or vascular component. It leads to either arterial thrombus formation or venous thrombus formation, and this is always associated with rise in the antiphospholipid antibodies. Common venous thrombus formation is a deep vein thrombosis, usually in the lower extremities, and common arterial thrombosis in the central nervous system. Cerebral thrombosis. So cerebral thrombosis is arterial, whereas the deep vein thrombosis usually in the lower extremities is venous, commonest venous thrombosis, which occurs because of the antiphospholipid syndrome, where there is a rise in the antiphospholipid antibodies is also seen. Obstetric antiphospholipid syndrome is called as OAPS. In these, there is presence of any one. Either there is a greater than or equal to one is episode of preterm delivery because of pre-eclampsia in a patient, or because of the placental insufficiency. PI is placental insufficiency, P is preeclampsia. I have used this short form so that there was a space crunch either here. Otherwise, these are not the standard short forms. Remember that these I am using it for my own convenience, but it is preeclampsia and placental insufficiency, or there can be greater than or equal to one episode of pregnancy loss where the duration of pregnancy is greater than 10 weeks, or there is presence of greater than or equal to 3 recurrent pregnancy losses where gestational age is 10 weeks and all these losses are unexplained. There is no identifiable etiology for this which is found. So any of these three, either history of preterm delivery because of preeclampsia, placental insufficiency, or there is a pregnancy loss greater than 10 weeks where there is no fetal abnormality which is found, or greater than or equal to 3 recurrent pregnancy losses very early, less than 10 weeks and unexplained. Any of these one along with raised antiphospholipid antibodies, that is the definition for this obstetric APS, obstetric antiphospholipid syndrome. So we have vascular antiphospholipid syndrome, we have obstetric antiphospholipid syndrome, and sometimes there can be a combination of these two in a same patient. Third is the most dangerous type of this antiphospholipid syndrome, which is called as catastrophic antiphospholipid syndrome, and other name for that is Usher-Son syndrome. What is happening here is there is a rise in antiphospholipid antibodies, along with there is a multi-organ failure. At least greater than 3 organs are showing a failure, and there is a rapid progress of the disease with a high chances of mortality with this catastrophic antiphospholipid syndrome, where there is a high levels of antiphospholipid antibodies are there, and there is a fast progressive disease which is seen, and that is why it is called as catastrophic antiphospholipid syndrome. Now, there is a path for pathogenesis of this obstetric antiphospholipid syndrome. There is a hypothesis which is called as two-hit hypothesis. Two-hit means there has to be some event which occurs in the body which leads to oxidative damage of cells either by infection or there is some endothelial disruption in the vessels. Some injury occurs where there is an endothelial disruption or there is a oxidative damage in the cells. That is the first damage which occurs. Then it is followed by production and binding of antiphospholipid antibodies. That is why it is called as a two-hit hypothesis, where there is some oxidative stress or there is some endothelial oxidative stress or endothelial disruption, which is followed by production of antiphospholipid, which triggers the production of antiphospholipid antibodies, which are binding with the phospholipids or with the plasma proteins associating with the phospholipids. That leads to either thrombus formation or trophoblastic damage, leading to either vascular APS or leading to obstetric antiphospholipid syndrome. So as diagrammatically we can see here two hit hypotheses. This is a vessel and these are the endothelial cells, and first there is some damage to the cell, endothelial cell. Oxidative stress is there, oxidative damage is there, or because of infection there is some damage. Then there is a production of antiphospholipid antibodies which are getting attached here and it leads to the formation of thrombus, and there can be even formation of intravenous placental thrombosis can also occur. That leads to the placental insufficiency and all the pregnancy complications. Now, what is the pathogenesis of this obstetric antiphospholipid syndrome? Now we have these three antibodies: mucus anticoagulant, anticardiolipin antibody, and anti-beta-2 glycoprotein 1 antibody. All these lead to cellular damage. How they are leading to cellular damages? They lead to vasculopathy by creating a procoagulant state. They lead to pregnancy morbidity by doing a trophoblastic and decidual damage, so that there is a less of trophoblastic invasion, less of modeling of spiral vessels. That is how it increases preeclampsia, fetal growth restriction, stillbirth, HELP syndrome, prematurity. All these are because of this action on trophoblastic and decidual cells. And third action, most important, is it increases the inflammation during pregnancy. So that is how these antibodies are leading to cellular damage, leading to pregnancy morbidity. Diagnostic criteria for the antiphospholipid syndrome is there has to be at least one lab test which should be positive, and there has to be at least one clinical criteria should be there. So any one of the lab test, any one of the clinical criteria. In the lab test, we have already seen we have three types of these antibodies: anticardiolipin antibody, anti-beta-2 glycoprotein 1 antibody, and mucus anticoagulant. Out of this anticoagulant antibody and this anti-beta-2 GP1, these are to be at least to be repeated 2 times and with an interval of 12 weeks, and there has to be increase in moderate to high titers are to be there to diagnose it as antiphospholipid syndrome. So these are the strict criteria for the diagnosis. Or even lupus anticoagulant, if we measure it, its value should be greater than 99 percentile. Any one clinical criteria, either patient should have a history of thrombosis or presence of thrombosis, which might be arterial or venous thrombosis, or obstetric morbidity should be there, as we have already seen, preterm delivery because of preeclampsia, placental insufficiency, greater than greater than or equal to one episode of greater than 10 weeks of a pregnancy loss, or more than or equal to 3 recurrent pregnancy losses where the gestational age is less than 10 weeks and these are unexplained. This, I think, we should all know this, because most important is correct diagnosis of antiphospholipid syndrome so that patient will respond to treatment, provided we adhere to this diagnostic criteria. What are the clinical features of antiphospholipid syndrome? We can remember it that way. There can be venous thrombosis, and commonest is in lower extremity as deep vein thrombosis. There can be arterial thrombosis, which is commonly present in the CNS arteries, leading to history of stroke in some patients. Hematological features we can get, such as thrombocytopenia and acquired hemolytic anemia, are commonly observed in these patients with these autoantibodies even acting against platelets, as well as leading to hemolytic anemia with the action on RBCs. Renal complications can be there because of the renal artery or renal vein thrombosis can lead to the renal failure in these patients, and pregnancy complications such as preeclampsia, Hill syndrome, fetal growth restrictions, stillbirth, and recurrent pregnancy loss. All these are the peculiar features for pregnancy morbidity or pregnancy complications observed with antiphospholipid syndrome. So this is diagrammatically, you can remember that the disease can affect vein, artery, it affects the formation of these cells which we observe in peripheral smear. You can remember as hematological changes. Renal changes can be there, and it can affect the pregnancy. Accordingly, whatever system is getting affected, the patient's presentation will be dependent on that. What clinical features patient will have. There can be combination of any one of these, or there can be only affection of a single system also. Indications to test for antiphospholipid antibodies are same as we have seen the diagnostic criteria to diagnose antiphospholipid syndrome. Any one of the obstetric morbidities such as fetal growth restriction necessitating preterm termination, preeclampsia necessitating preterm termination, pregnancy loss greater than 10 weeks with no fetal cause identified, or recurrent pregnancy loss more than 3, which are early, less than 10 weeks, and unexplained. Any one of these is an indication to test the patient for antiphospholipid antibody titers. Or if there is a history of vascular antiphospholipid syndrome, such as deep vein thrombosis in lower extremity, cerebral arterial thrombosis with a history of stroke or pulmonary embolism. So three types of antiphospholipid antibodies are anti-cardiolipin antibody, which is either IgG or IgM type, which can be detected by doing ELISA test. Anti-beta-2 glycoprotein 1, anti-beta-2 glycoprotein 1, again done with the ELISA, and two types are there, IgG or IgM antibodies. And lupus anticoagulant antibodies, where the test which is done is called as functional clotting assay. And these are the three types of antiphospholipid antibodies which might one, sometimes even only one is raised, or sometimes there can be combination of more than one which are raised in a given patient. Impact of raised antiphospholipid antibody titer is, what is the implication is, if lupus anticoagulant is positive, there is a maximum pregnancy complications are observed. So pregnancy morbidity is maximum with the lupus anticoagulant antibody, followed by anti-beta-2 glycoprotein 1 antibody titer, where fetal growth restriction is more common with this. And the comparatively weakest of these is anti-cardiolipin antibody, leading to some less number of cases with pregnancy complications. But remember that whenever there is a combination of these two, anti-cardiolipin and anti-beta-2 GP1, then the risk increases, pregnancy complications are more. Greater than one antibody positivity is associated with greater risk of obstetric APS. And some patients, there can be mitral valve vegetations are observed leading to mitral regurgitation in some of the cases. Features of obstetric antiphospholipid syndrome: obstetric complications such as recurrent pregnancy loss, fetal growth restriction, early onset preeclampsia, even HELP syndrome can occur, stillbirth and preterm birth. Thrombotic complications during pregnancy can occur such as CNS thrombosis, psychosis can occur, renal vessel thrombosis leading to renal failure can be there, or peripherally there can be deep vein thrombosis. So venous thromboembolism also can occur. And rarely during pregnancy we can have catastrophic antiphospholipid syndrome, which is associated with a high mortality. So we have seen the diagnostic criteria and we have seen what are the indications to test for antiphospholipid antibody syndrome and what are the clinical features of this antiphospholipid syndrome. And now we come to the last part, that is the treatment. If antiphospholipid antibody positivity is there, how in pregnancy, how we should treat. Now if it is only the antibodies which are positive and there are no features of vascular antiphospholipid syndrome or obstetric antiphospholipid syndrome, in other words, it is only the antibody titer raised, but no APS, no antiphospholipid syndrome, then only surveillance is indicated. If there is only presence of vascular APS, history of arterial or venous thrombosis or presence of arterial or venous thrombosis, along with rise in antiphospholipid antibody titer. In these cases, heparin is indicated and role of aspirin is doubtful. Whereas for if there is obstetric APS, then heparin along with aspirin is indicated and it has a this combination leads to 70% success rate. But in 30%, in spite of giving this, there can be a pregnancy loss. We should not be giving estrogen containing hormonal preparations or contraceptives whenever patient has antiphospholipid antibody titers are raised or positivity is present. Hydroxychloroquine at present is in the research is a drug for treatment of APS during pregnancy. Now coming to use of aspirin in obstetric antiphospholipid syndrome. Low dose aspirin is given as 60 to 80 mg per day orally. It leads to decreased platelet aggregation and decrease in the vasoconstriction. What is the mechanism of action? Now this I think that each postgraduate student, now you are likely to ask what is the mechanism of action of aspirin in your table viva also, where we have drugs kept on the table viva and you are asked about, sometimes some drugs are asked, and in that if aspirin is kept, you should be knowing this mechanism of action by heart. How aspirin acts whenever it is given during pregnancy in these cases of obstetric antiphospholipid syndrome. So what aspirin leads to is its action is it prevents conversion of arachidonic acid to thromboxane A2. So the thromboxane A2 formation is reduced with the whenever we are giving low dose aspirin to a patient. Because there is a reduction in thromboxane A2, there is a reduction in platelet aggregation and vasoconstriction, because thromboxane A2 leads to increase in platelet aggregation and vasoconstriction, whereas prostacyclin has exactly opposite action. It will lead to less platelet aggregation and it will lead to vasodilatation. It will reduce the vasoconstriction. Now with this aspirin, it reduces the level of thromboxane A2, but it has no action on prostacyclin. So prostacyclin level remains normal. That means what is happening ultimately is there is a greater action of this prostacyclin, and ultimate result is reduction in platelet aggregation as well as less vasoconstriction whenever we are giving patient low dose aspirin. This is the mechanism of action, where the first link is it prevents conversion of arachidonic acid to thromboxane A2. this aspirin, low-dose aspirin is relatively a safe drug to be given during pregnancy, but only thing is it might lead to slight increase in small vessel bleeding during surgery in some patients. This we need to remember, that there can be a slight increase in small vessel bleeding during surgery. Suppose patient is on aspirin and we need to do an emergency cesarean section, we should remember that the small vessel bleeding or ooze, might be some oozing in the surgical field whenever we are doing it. Though we continue aspirin in third trimester also, in some patients, rarely it can lead to this slight increase in small vessel bleeding. This aspirin is indicated in antiphospholipid syndrome, and also it is indicated in systemic lupus erythematosus, SLE patients, but aspirin is not indicated if there is only increase in antiphospholipid antibodies. So if antibody titer is raised, that is not an indication to start aspirin, because it has been seen not to change the outcome if there is no APS, there is no antiphospholipid syndrome, and only the antibodies are raised. Heparin in antiphospholipid syndrome, we have to, as you all know, that we have two preparations which are available, either unfractionated this heparin or low molecular weight heparin. Whenever we give unfractionated, the dose is 5,000 to 10,000 units subcutaneously, which is given on the 12-hourly schedule. Whereas low molecular weight heparin, commonest preparation is, one example is enoxaparin, which is given 40 milligram once a day. Now this unfractionated heparin is cheaper, but the complications which are present inherently seen with the heparin uses by increase in the bleeding tendency, thrombocytopenia, osteopenia or osteoporosis. All these complications are less with low molecular weight heparin as compared to unfractionated heparin. With low molecular weight heparin, only thing is it has a longer half-life. That is why we are giving it on a once a day basis, but it needs to be stopped earlier before surgery. That means its action will be lasting for a longer time as compared to unfractionated heparin. Mechanism of action of heparin is it binds with beta-2 glycoprotein 1. It also binds with other antiphospholipid antibodies also, such as anticardiolipin antibody and lupus anticoagulant antibody. With that, as it binds with this beta-2 glycoprotein 1 and as it binds with other Apla antiphospholipid antibodies also, what heparin leads to is it prevents microcirculation thrombosis in placenta, as well as it prevents vascular is either arterial or venous thrombosis formation. So main action of heparin is for prevention of this thrombosis, vascular thrombosis, as well as it prevents placental damage, placental insufficiency because of this microvascular thrombus formation, so that there will be reduction in preeclampsia, Hell's syndrome, preterm deliveries. There will be reduction in recurrent pregnancy loss with the use of heparin. That is how it acts in obstetric antiphospholipid syndromes. It is used as to prevent occurrence of vascular thrombosis as well as to prevent pregnancy complications, because it is preventing microcirculation thrombosis which occurs in placenta. Other drugs which have been tried are corticosteroids are tried, but these are to be given only when there is a combination of antiphospholipid syndrome along with systemic lupus erythematosus. Intravenous immunoglobulins. Intravenous immunoglobulins are given with a dose of 1 to 2 gram per kg per month. That is a dose for intravenous immunoglobulins. It is given when either there is a catastrophic antiphospholipid syndrome or heparin-induced thrombocytopenia. These are the indications to give this intravenous immunoglobulins. Now, this is quite expensive drug, and its efficacy has not been proven beyond doubt in recurrent pregnancy loss with antiphospholipid syndrome. Other drug which has been tried is hydroxychloroquine. as an immunosuppressant whenever there is a combination of antiphospholipid syndrome along with SLE. Statins, these are the newest addition to the drugs which are under research, which are being tried along with heparin and aspirin to reduce obstetric morbidity in patients with antiphospholipid syndrome. Neonatal effects of this passive transfer of antibodies to the baby. During pregnancy, the antibodies which are present, antiphospholipid antibodies which are present in maternal circulation, they are getting transferred passively to the newborn baby. And it has been seen that in babies, whenever there is a rise in antiphospholipid antibodies, there is increase in possibility of increased possibility of learning disabilities, increased autism has been observed in some of the studies, and it is associated with increase in low birth weight and prematurity. Thank you so much. Most of the content I have taken from Williams Obstetrics 2019, and some of the basics, what are the phospholipids and what is the pathogenesis, that I have taken from the some of the articles which are available on internet. Thank you once again.